All right. Well, welcome back to Ultrasound Grand Rounds again this week. I'm pretty excited to be with you as always. Last time we talked, we were going on this theme of left ventricular ejection fraction estimate. We talked about the endpoint septal separation technique or EPSS technique to figure out what the LV ejection fraction is. Today, we're going to talk about yet another technique we can use, yet another tool in our tool chest that can help us find the left ventricular ejection fraction. So without further delay, let's dive on in and talk about some fractional shortening. Last time we talked about endpoint septal separation as a technique that we can use to augment our visual estimate for left ventricular ejection fraction estimation. And today, what we're going to do is we are going to talk about yet another technique that we can use to help us identify what this patient's ejection fraction is and really provide the most excellent care possible for these patients in the emergency department and for those of you guys who are in the critical care environment upstairs in the critical care environments. So let's dive on into today's topic. So if you remember from a couple weeks ago, we started off with this case. And I would like to start off again here today because I think this really sets the scenario, reminds us of what we were talking about before, and kind of primes and tunes our mind to start thinking about what we want to be discussing with is endpoint septal separation technique from last time and fractional shortening from this time. So if you remember, we had this hypothetical case. And again, I say hypothetical because I want to preserve all HIPAA anonymity and I don't want to get in trouble. But yet, this would be like a composite of patients that I think any of us could, say we've seen in the emergency department, right? So I haven't seen this precise patient, but I've seen patients just like this probably as recent as this last week, right? So this is a 65-year-old gentleman who presents to the emergency with shortness of breath, and he has the vitals that are as listed, right? Blood pressure 148/85, heart rate 85, respiratory rate of 20, 90, 95%. So real no smoking guns, but he's got history of hypertension, probably some CAD mixed in there, probably some type 2 diabetes mixed in there, and now he's presenting with shortness of breath, and we need to figure out what precisely is going on with this patient. And so when we go to the clinical exam, we have, again, this, obese gentleman, regular height and rhythm, no murmurs, rubs, or gallops. He's got some tricerals in the bases. His belly, extremities, and skin are all decently unremarkable, except for some edema to the lower extremities, right, up to the mid tibia, some pitting edema. And so it's kind of painting this picture of, this heart failure type exacerbation, right? And we went through this whole differential last time. I'm not going to really belabor this point because go watch last time's video, right? But we went through this differential of what could be causing shortness of breath and really landed on this idea of heart failure as we've gotten our EKG, we collected our chest x-ray, we got our labs, things like that. And we talked a little bit about this idea of heart failure is essentially the heart cannot, the heart's pump, right, cannot keep up with the blood flow demands that the body has, right? The pump has gotten inefficient in some capacity, whether it be it can't pump effectively, it can't relax effectively, whatever the case may be, it is failing. The body's not getting the blood that it needs, and it is going to result in a constellation of symptoms that present with this shortness of breath, right? Edema, weight gain, decreased perfusion, et cetera, et cetera, et cetera. And we talked a little bit last time about how echo is really the critical test because that's the test that looks at the heart function. Right? We can look and see what is this heart doing? What are the external factors? What are the internal factors? What are the myocardial dynamics, as it were, that really affect the ability of this heart to pump. And so that's going to be what gives us our answer to what we're looking for. And we talked a little bit about how the normal ejection fraction is something greater than 50%. And so if we're less than 50%, we're kind of delving into that realm or tipping our toe into the water of heart failure. And the degree to which you have your EF is less than 50% is the degree to which you have heart failure, at least in reduced ejection fraction. Grant, there's a whole bunch of other categories with preserved ejection fraction, things like that. But this is kind of the broad brush description of heart failure itself. And so we talked a little bit about these two different types of patients, right? These two different windows. So the parasternal long axis window in two very different hearts, and the one on the left is squeezing quite normally, right? It's squeezing and has a pretty decent ejection fraction. And the one on the right, you can tell just by looking at it that the ejection fraction is a lot worse than the one on the right, right? It's not squeezing well. The wall is not thickening very well. The mitral valve's not opening very well. It's just not as effective at pumping the blood as the one on the left. And so this is an idea of the visual estimate can give us a very big gestalt of what this patient's EF is doing. That being said, there are cases where this is challenging to discern. And I think I've been doing a particular focus on the QA that I've been doing recently on cardiac ultrasound in our cardiac ultrasounds in the emergency department to see how accurate our EF assessment is compared to an echo that's done next day. And, in certain cases, there is a little bit of a discrepancy of what we may call and what's officially reported out. And a lot of these, it's those in-between cases. Some of them, I look at it and it's okay, there's an issue we have to, rectify here. But a lot of them are these in-between cases where it's like, man, you look at it, depending on the view that you look at, it may affect what you think. And they're really kind of that questionable case of, is this reduced? Is it not reduced? It's hard to tell. And so having some extra tools in our toolbox can really be helpful as we try to discern what's the best thing to do. And so last time we talked about this endpoint septal separation technique, the EPSS technique, where we looked at an M mode tracing through the mitral valve leaflet tip and saw how close that mitral valve leaflet tip got to the septal wall. And we use that as a correlation to left ventricular ejection fraction, right? And so we saw that there was an inverse relationship between the EPSS measurement and LVEF, meaning if your EPSS measurement is less than 7 millimeters, you tended to correlate with a normal ejection fraction, compared with one that was greater than 7 or greater than 12 millimeters, it correlated with a progressively reduced ejection fraction. And we talked a little bit about how there are some pitfalls, right? And one of the potential pitfalls that we ran into is mitral stenosis. So for the sake of today's conversation, let's assume that this patient that we have today has one of those pitfalls, namely mitral stenosis or some other thing, and really makes EPSS not a valid technique to be able to utilize as we're scanning these patients. And so that brings us to the second technique that I wanted to talk about and spend the duration of our time on today, and that is fractional shortening. So it's another technique that we can use to assess the left ventricle, and we can correlate it with left ventricular ejection fraction. And one of the unique things about fractional shortening compared with EPSS is it actually starts measuring ventricular function. So if you remember last time, one of the critiques of EPSS is it's a correlative measure, but it's not directly measuring ventricular function, meaning you're measuring the excursion of a valve, which is highly dependent on blood flow through the valve or around the valve, in the case of regurgitant flow out of the aorta. And that can affect what that valve does. And while it does correlate in most cases, there are some certain circumstances when you're looking at a non-directly correlative value, you can kind of get in a little bit of trouble here. And so what I'm trying to say here in a very inarticulate way is when we measure fractional shortening, we're actually measuring the movement of the ventricle. We'll see that here in a little bit. And so it's a little bit more directly correlated with the left ventricular ejection fraction with some caveats. And that's what the duration of the lecture is. So keep listening. But before we get into fractional shortening as a technique, what I wanted to do is back up and spend a little bit of time just talking about the left ventricle, helping us understand or remind ourselves of the left ventricular anatomy, because that's going to be really important as we then determine, well, how do we figure out an ejection fraction in ideal circumstances, and where does this fractional shortening technique fit into that bigger framework of what the LV is doing and what the math would have us do to figure out the ejection fraction. So in broad terms, right, the myocardium is made up of 3 distinct layers. We tend to think of a muscle, like the bicep muscle or the tricep muscle or a hamstring muscle or a quad muscle as this, attachment, origin, insertion, it attaches in 2 places and it pulls in one single solid, direction, right? And that's what, if you think about the bicep, that's what it does. You are lifting a weight or you're curling your arm or whatever, and it contracts in a single longitudinal direction, and it pulls that lever essentially in a certain direction. The heart muscle is a little bit different, right? It is a muscle. It does have those properties of muscles that make muscles work. But if we remember back to our anatomy, the muscle of the heart, the fibers of the heart are arranged in different configurations, not all in a linear configuration. So it becomes really important as we break this down. We have the endocardium, right? We have the myocardium, that big bulk of the muscle, and then we have the epicardium on the outside. And obviously outside that is the pericardium, but it's not the muscle part, so I left that out here. And so as we think about this muscle array, each of these different layers are going to have a different orientation of those muscle fibers, which will then result in a certain pattern of contraction for the left ventricle. So let's dive into that a little bit. So in the innermost part of the heart, we have the endocardial muscle fibers, and these tend to have a longitudinal orientation or configuration, or longitudinal array. And so when you contract these muscle fibers, it tends to pull the ventricle in this long axis orientation relative to the ventricle. It tends to pull it, kind of shorten that down a little bit. Contrast that with the middle layer. The mid-wall fibers tend to have a radial orientation. They are oriented kind of around the radial circumference of this ventricle. And so when they contract, what tends to happen is a lot of this contraction of the ventricle towards the center. And so one of the things that I like to do when I'm scanning, particularly the parasternal short axis, which is what we see here, looking for regional wall motion abnormalities, is to literally put my finger in the middle of that screen, right? And okay, don't touch the screen because it makes it all dirty, and all these people who are obsessing about fingerprints on your screen, like myself, don't like that. However, if you kind of put it towards the middle of the screen, you can then watch all those different walls and see if they contract towards your finger. That's what I like to do. And that really just highlights the fact that these mid-wall fibers, when they squeeze in that circumferential orientation, what it does is it pulls that ventricle towards the middle, right? Those endocardial fibers pull it in the long axis. The radial fibers pull it towards the middle in this circumferential orientation. And then finally, the epicardial fibers tend to have an oblique orientation, right? They don't follow a strict longitudinal. They don't follow a strict circumferential. They're obliquely wrapped around the ventricle. And the net effect is when you have all these fibers firing, right, you, instead of having a bellows effect like you get predominantly with the right ventricle, you get more of a ringing of a rag. So imagine yourself, wiping your counter or your table off at the end of a dinner or something like that. You get your dish rag all wet and you take it in both hands and you twist your hands in opposite different directions. It's going to have some of that radial orientation in, but it's also going to have that oblique where, twist to really kind of wring out all that water. And this is what the ventricle is going to do. Now, in reality, this is an oversimplification. Right? There's some studies that are quite mind-boggling and dizzying, but they exist, that show the vast geographical array of different fibers, even in different patches throughout the heart. And so the specific reality is a little bit more complex and nuanced this, but broadly speaking, you have these three orientations of fibers that result in the left ventricle doing this twisting motion to get things out or get the blood out of the heart. And so where this becomes practical, other than just kind of this theoretical, cool, that's great, what do I do with this now, Matt, is you have a hard time measuring one of these parameters and getting an accurate assessment of what the actual left ventricle function is. And this is really where it gets important with the fractional shortening. And I'll say it now in case I forget to say it later. The fractional shortening is measuring one dimension, right? It's measuring that radial squeeze of those mid-wall fibers, and it's correlating that with the other two, or it's assuming the other two dimensions are consistent, and really estimating that to be consistent with the ejection fraction. So what we have to realize is as we go into the actual three-dimensional geometry, it's a lot more complex than one dimension will say. And so this is where some of the pitfalls of the fractional shortening come in. But let's talk about this three-dimensional modeling so that we can have a little bit better understanding of how the fractional shortening works. And so next, what I'd like to do is just say, in ideal circumstances, right, in the echo lab, how do you assess for left ventricular volume? right? And then what we'll do is do it in systole and diastole and then compare the two. And that gives us our ejection fraction, right? The proportion of blood that's squeezed out of the heart every time the heart beats. And so if we take this model that we made, right? I took that ellipse and turned it upside down, right? And so imagine we're looking at the left ventricle part of maybe an apical four-chamber view, right? So this is the parabolic structure of that left ventricle, right? If we oversimplify it, put it here, and then we superimpose that on a graph, right? Remember this from way back when in high school geometry and trigonometry, right? You have your X and your Y axis. So we're going to superimpose this parabolic structure onto a graph. And with that, oversimplified parabolic structure, we can then turn that into a mathematical equation. And so in this situation, I'm just assuming just a real simple parabolic expression here, y equals minus x squared plus 4. And so essentially what we're doing, and for those of you guys who don't love math, I know you're kind of glazing over. I'm like, oh boy, this is going to be a long lecture. This is going to be rough. Essentially what we're doing is saying, the x squared is the parabola, right? If we just did y equals x, it's going to be a straight line, right? But if we do y equals x squared, that's a parabola, that's that arc. And then by saying plus 4, I'm just saying, you know what? Scoot the top of that parabola up to the unit number 4 on the y-axis, right? And since it's x squared, it's going to come down neatly to minus 2 and plus 2 where it hits the x-axis. And I just did this for simplicity's sake as we start plugging this into some formulas. And the negative basically means the parabola is oriented the way it is. If we did positive, it would just be oriented the opposite direction relative to the y-axis. So anyway, we can basically take our left ventricle and we can turn it into a mathematical equation that we can then plug in to figure out some geometries here. And so when we try to calculate this, the volume, right, of the left ventricle, we can assume, like, let's take that parabola, let's flatten it out. And if we somehow can calculate the area of that parabola, the area under that curve, above the x baseline and then between the curves, and then spin that around its axis, we can then really easily calculate a volume. And so this is basically simple calculus, doing some integrals to get this. And the way this is done, at least conceptually, is this idea of these stacked columns, right? And so if you basically say, hey, I got a column that's a certain width, certain height, goes up to that line, I can stack a bunch of those columns next to each other, find the area of those columns. That's pretty easy. Add all that up, boom, Bob's your uncle, and we have our area under that curve. In the degree to which I make those columns narrower, the more accurately we can resolve that actual area under the curve, right? If I do the big boxes, there's going to be some gaps that I just can't measure, and it's going to be inaccurate. If I make those boxes smaller, it's going to make that more and more accurate. And so this is where the calculus comes in. And essentially, we can say we're going to make the box width infinitely narrow, right? So I can fit as many of them under there, get as closely accurate to that curve, and plug that into this integral formula, and I can then come out with the area under that curve. And that's pretty much as advanced as we're going to go with the calculus. My goal isn't necessarily to have a refresher. Well, I am trying to have a refresher of high school and college calculus, but that's kind of the theory behind that, right? And so we can have this whole measurement of those boxes under the curve, right? Just like we see here, we can plug that into the integral formula saying, I want to measure it from -2 to +2. What's the whole area under that curve? Give me that. We're going to plug it into a formula and we're going to find a volume. And so to do that, we essentially say our volume is, or we can get the area here, and our volume is equal to, let's go to this slide, right here, our volume is equal to our area times our height, right? Just a simple geometric equation. So if I can calculate an area and a height, then I can get essentially the volume. And so going back to this one, essentially in ultrasound, what we're going to do is instead of stacking these columns vertically, we're going to stack them horizontally. You're going to hear this stacked coins or stacked discs method of calculating left ventricular volume. And so we find all these things. We integrate the area under that curve, and we can really, at the end of the day, come out with a volume after we multiply it with pi and all sorts of other calculations. And so I know it's complex. It's a little bit nerdy, kind of getting into the calculus of how we measure. But what happens, right, in the ultrasound machine is the machine does this for you, right? And when you're doing your ultrasounds, you can actually have the machine produce the calculus to give you some volumes. And so this is what's called the Simpson's method for left ventricular ejection fraction. So coming back down to earth here, when you go to the echo lab, right, and you have the sonographers measure your left ventricle, they're going to measure this area under a curve, right? They're going to do an apical 4-chamber and then turn it in short axis and do an apical 2-chamber. And they're going to measure, just draw a line, or oftentimes the computer will come up with that line. You can adjust it a little bit on your own, but you're going to draw a line that inside that ventricle, and the machine's going to assume some stacked discs, right? And it's going to basically do that calculus equation, that area, or integrate the area under a curve, and then with the 2 dimensions, you can get a volume and really say, what is the volume of this ventricle in diastole, right? And then what is the volume of this ventricle in systole? And we can compare the two, and we can get a fractional, proportion of the change, and that is our ejection fraction. So that's how this Simpson's method happens on its own, right? But what you can see here, and by going through a lot of this calculus, and by going through the videos or this clips and putting the stacked discs overlying all this, you can really see that this is a very 3-dimensional structure, or there's a very 3-dimensional calculation. But when we come down to doing fractional shortening, we're going to measure one of those dimensions. And so Simpson's is considered to be the most accurate method, right? Everything is compared to Simpson's when you do these accuracy studies of some technique versus echo. It is the most accurate. And so fractional shortening is going to be one of those 3 dimensions as we measure this in basically 2 dimensions. So let's move on from there and actually get into the meat and potatoes of the fractional shortening, because all that's great theory, all it's interesting and fun to talk about academically, but practically, what am I going to do at the bedside? Not pulling out my calculator and doing calculus to figure things out, right? So fractional shortening is this technique that we're going to use to measure our left ventricular ejection fraction. So essentially what we're going to do is we're going to start where we were before, right? We're going to start with that parasternal long axis window. So we were in this window when we did our endpoint septal separation. We moved our ultrasound caliper, or the M-mode caliper, right over that mitral valve leaflet tip. This time we're in the same window, but we're going to move that caliper a little bit more, and we're going to get a different measurement. And so let's talk a little bit about that measurement that we're going to get. So the landmarks we're looking here are 2 things. Number 1, we're looking for that mitral valve leaflet tip, right? And we're looking for, number 2, the tip of the papillary muscle, right? So we can see that in this window here. You can see that mitral valve leaflet tip tethered to the papillary muscle via the chordae tendineae, between those 2 arrows. And so what we want is the widest area of that left ventricle. And generally it lives between these two arrows. So if you measure it over the mitral valve, you're going to get some artifact of the mitral valve. If you measure it over the papillary muscle, you're going to get some artifact from the papillary muscle. So we really want it just distal to the mitral valve leaflet tip, but proximal to where that papillary muscle would be. And we're going to put our M-mode caliper right through that area. Now, one little technique that I found is, depending on what angle you have your probe set at, it can kind of adjust a little bit of what fractional shortening you get. And one of the things that can get in the way is this papillary muscle chordae tendineae complex. And so what I've found to be helpful is, when you find that area, when you find your mitral valve leaflet tip, when you find where your papillary muscle is, just fan off axis just a little bit so that papillary muscle disappears, and you'll see that left ventricle open up a little bit more, just a little bit. And that's where you want to put your M-mode caliper in this window. And so here's an example of that. You can see the mitral valve leaflet tip, and we went just a little bit beyond that, fanned out so that papillary muscle is just out of the way. You can see the base of it on the far left-hand side of the screen towards the apex of the heart, but it's not in our way for this this calculation. And we put our M-mode line right through that area, looking at really that widest area of the heart. And we're going to see how much excursion happens when we go through a contraction cycle. And so if we put our M-mode, we activate our M-mode tracing, we're going to get something that looks very much like this. And so obviously the big middle black line is going to be the left ventricle, the lumen of the left ventricle. And so that undulating line above it is going to be the septal wall, and the big undulating line below it is going to be that that free wall of the left ventricle. And so what we're looking for is in systole, we're looking for the contraction, that narrowest place. So when systole happens, it squeezes and everything kind of goes closer to each other. And then in diastole, as the blood fills the chamber, we're going to see that open back up. And at end diastole, when the ventricle is filled by itself as much as possible, the atria is just popped in that little extra. We see it as big as it gets, measure those two values, and we can plug it into a formula to get our fractional shortening number. We'll talk about that in just a sec. Alternatively, we can also utilize the short axis window. So essentially, we're measuring the same thing. Fundamentally, we're looking at the AP diameter of the heart, either in long axis or short axis. And so we've only turned our orientation 90 degrees to look at either, the long axis of the heart or the short axis of the heart, but AP theoretically should be the same thing. And so you can put your M mode caliper through the widest area of the short axis of the heart. And again, same spot, just below the mitral valve, just above where you'd see the papillary muscles. And you can activate that same M mode tracing to get a similar looking result using the short axis. And then we can use that to make our calculations. So this brings us to the question then, how do we interpret the fractional shortening? How do we okay, so fine, I got two numbers. What do I do with these things? What's the formula you keep telling me about? And how do I make decisions off that? And so what we're going to do is essentially come down to this formula. So left ventricular ejection fraction using I shouldn't say left ventricular ejection fraction, the left ventricular fractional shortening percentage. We're going to get a percentage that we're going to obtain is equal to the end diastolic diameter minus the end systolic diameter. So the widest minus the smallest, right, or the narrowest, over the end diastolic diameter, so the widest, times 100, so that we can present this thing out in a percentage. So we're going to get widest minus smallest over widest times 100, and that's going to give us a percentage, and it's going to be somewhere in the neighborhood of 25 to 35%. And so the way we interpret is basically say anything above 25% is generally considered to be normal. That being said, there is a slight male to female difference, right? So I don't remember off the top of my head, but one of them is 27, one's 25 for the bottom of the values, around 27, 25. But if you basically just remember the 25 to about 45 is generally considered to be normal left ventricular ejection fraction. If it's over 45%, that's considered to be hyperdynamic. And then in this range below 25%, we can parse that out to be a little bit more nuanced and say, okay, if it's closer to 25, we're mild. We're kind of 20 to 25, we're moderately reduced. And then if we're less than 20%, we're pretty severely reduced. And there's a couple different scales that kind of measure the numbers in a couple different ways. But if we're kind of in this ballpark of 20 to 25% is moderately reduced, or mild to moderately reduced, less than 20 is moderately to severe. And then I've heard some like in the teens, it's like very severely reduced. That is kind of how we're going to interpret this left ventricular fractional shortening, right? So here's another example, right? This was someone who's got a very poor left ventricular ejection fraction. So we can see on the apical view on the right, there's just not a lot of excursion like that. Just by visual estimate, we say, yeah, this is pretty low in terms of our estimated ejection fraction. And then when we go in the short axis view on the left here, we can see that there's very little excursion of the two different walls, giving us about an 8% fractional shortening, which would really correlate with a very severely reduced ejection fraction that we see in the right-hand image on the apical forechamber. So that's essentially fractional shortening, how it's done. Before we finish things up, I want to talk a little bit about some pitfalls and limitations, right? Because it's not perfect, right? As I've done this myself, I've found some areas where I just struggle trying to figure out how to make this work. And so I want to talk a little bit about these pitfalls, limitations, so that we can really nuance this a little bit and have a better understanding of how to use fractional shortening in our clinical care, right? So the first one is like last time, this is the slide from last time for EPSS, it is dependent on the angle, right? So you need to be perpendicular to the septal wall of the left ventricle. So tilt that probe until the septal wall is perpendicular to your M mode axis, right? To the extent that you're perpendicular, you can get the most accurate measurements, you get the most accurate fractional shortening estimation for your patient. If you're angled like this, you got to move that, right? It's going to give you an inaccurate number. The second one, which was interesting to me, is there is some degree of preload and afterload dependence for fractional shortening. And this comes out of a study that I thought was interesting. I'll show you here in just a sec. But if you look at this one, like this is a patient who has a just ginormously plump IVC, so it's going to have a little bit more preload than someone who's maybe that IVC is super duper flat. And so the study that I was talking about earlier was this one, is basically limitations of fractional shortening as an index of contractility in pediatric patients with HIV. And so granted, it's a very nuanced cohort, but what they found is essentially when the patients had, they compared like fractional shortening to, contractility of the left ventricle. And when they had a very high preload condition, they found that fractional shortening overestimated the contractility. So when you pump a ton of stuff in there, there's a little bit more stretch reflex, that heart tends to squeeze a little bit better. And then if you have a lot of high afterload, right, this one makes a little bit of sense, the fractional shortening tend to underestimate contractility. It's just a little bit more you have to pump against. And so to what degree is this clinically significant in most of our patients? Not entirely sure, but there is some data that suggests that, if you're on your extremes of your loading conditions for your heart, you may struggle in having this particular one accurately assess the actual ejection fraction. You may need to either correlate it with other indices or look at other ways of finding your left ventricular ejection fraction. All right, the next one, and this is where I found a lot of, I guess, variability, and a lot of this one's really important, is the caliper location in the windowing that you utilize. And so we can look at this one, for example. This is a left ventricle that is very, very thickened, right? You can see the ejection fraction is quite low, and we can take this particular patient, right, and do fractional shortening through a couple different places, and we get very, very different numbers. And so on the left, and again, same patient, right, on the left, we have one that shows, a change of 28.8%, and on the right, we have one that shows a change of 8%. And I think using the visual estimation, I tend to believe the 8% one a little bit more than the 28% one. And so you have to be very careful where you place your caliper. And we can see a little bit of the mitral valve kicking in the one on the left. And the other thing that can actually affect this to a degree too is getting out of the way of that papillary muscle. And so here's another example. We can see, just based on where we put our caliper, right, on this patient. So this one clearly, reduced ejection fraction. Where we put our caliper, we have a 21% and a 16%. And if you put it closer to a valve, put it farther away from the valve, if you involve the papillary muscle, it can affect the measurement you have. And so this is why I say get it just distal to the valve. Make sure that ventricle is decently unobstructed, right? The papillary muscle doesn't come into the window or the path of the mitral valve, or the M mode caliper, and you're going through that widest area of the ventricle, and you're going to get your most probable and likely estimate of this person's left ventricular ejection fraction. And the final one, and this one's actually really important, is regional wall motion abnormalities. And so if we look at this patient here, this is someone who has definitive regional wall motion abnormalities. And so if you can see in the apical view on the right, there's definitely a lot of movement closer to the valve, and there's not a lot of movement as you go out distal into the apex. And so you can see if you run the M mode caliper, and obviously you're not doing it in the apical window, but if you were able to do it through the apical portion versus through the basal portion, you're going to get two very different numbers. And since regional wall motion abnormalities aren't uniform, right? They're regional. They follow a vascular territory. Depending on which angle you cut through the heart, you may actually catch that abnormality or you may not catch it. And those two different slices will give you two very different numbers for your fractional shortening. So you can see, the peristernal long, the peristernal short, and kind of how those stunned walls, kind of on that lateral portion versus the moving walls and the septal portion at least in the peristernal short, can really affect that fractional shortening depending on where you put your caliper. And so those are a couple of the pitfalls. As we kind of wrap things up today, wanted to just kind of briefly hit and review. Fractional shortening is yet another tool that we can utilize to help us estimate left ventricular ejection fraction. It's best done in the widest unobstructed area of the left ventricle, usually distal to the mitral valve leaflet and proximal to the papillary muscle, papillary muscle tip. You take two measurements, your end diastolic, end systolic measurements, plug it into this formula, it's diastolic minus systole over diastole times 100, and that's going to give you a number that you can then correlate with your ejection fraction. And so between 25 and 45 is generally considered normal. Less than 25 to 25 is considered reduced, and less than 20 is considered to be generally severely reduced. Well, thank you so much for joining us today. I hope you found that helpful, informative, something that you can take to the bedside and use on your patients in your next shift as you really assess these patients for their left ventricular ejection fraction and use the EPSS technique and now the fractional shortening technique to really hone in and improve your skills. If you found this helpful, definitely hit that subscribe button, that notification bell down below, and even let us know in the comments what you liked, what you didn't like, some thoughts that you have, how you might be using fractional shortening in your own practice or how you intend to use it now. If you're interested in training ultrasound with us as a medical student, as a resident, or as a fellow, head on over to metrohealth.org/POCUS. You can learn about our program. And if you missed the EPSS video from last time, I will put that link in the end card and the description below. Have a great week, guys. We'll see you next time. Take care. Bye.